a minute or two early. I'm Richard Shilsky. I'm ASCO's Senior Vice President and Chief Medical Officer, and really pleased to welcome you back for the second press briefing of the 2019 ASCO annual meeting. We have 5 presenters this morning who will provide new insights on the use of precision medicine to better tailor treatments for patients and target hard-to-treat cancers, as well as issues impacting access to cancer care. 3 of the studies will also be presented in ASCO's plenary session later today. Joining me on the podium are ASCO experts Mary Jennifer Markham, Dr. Catherine Diefenbach, Dr. William Dale, Dr. Neeraj Agarwal, and Dr. Suzanne Cole, who will provide additional context about the studies highlighted today. As usual, we ask that you use our ASCO affiliations for the purposes of attribution in your meeting coverage. Now, our first presenter, if all goes well, is going to be joining us on the phone. Her clinical responsibilities have prevented her from actually attending the meeting, which is good for her patients, but not so good for us. Dr. Anna Jo Smith is a resident in the Johns Hopkins Department of Gynecology and Obstetrics in Baltimore. She will present the findings from an analysis of the National Cancer Database looking at the correlation between the Affordable Care Act and early-stage ovarian cancer diagnosis and time to treatment. So, Dr. Smith, if you're on the line, the floor is yours.
Yes, this is Dr. Smith. Thank you so much to ASCO for their interest in our project and especially for allowing us to present remotely. I will be talking today about the effects of the Affordable Care Act on women with ovarian cancer. And this is partnership with the head of our Department of Gynecologic Oncology, Dr. Amanda Nichols-Spader. So as we know, ovarian cancer is the deadliest of gynecologic malignancies. Around 22,000 women each year are diagnosed in the U.S., and more than half of them will be dead within 5 years of diagnosis of ovarian cancer because most women present at late stage of disease. We have no screening for ovarian cancer. However, there are subtle signs and symptoms, abdominal pain, abdominal bloating, change in bowel or bladder habits, that if women have access to care, they do tend to seek out care for and may be able to be diagnosed earlier. Advanced. So our question then was, what was the impact of the Affordable Care Act, which we know improved in access to insurance in the U.S. and access to primary care, on stage at diagnosis and time to treatment in ovarian cancer? There are multiple provisions: the dependent coverage mandate that expanded access for young women, premium subsidies and Medicaid expansion that expanded access to insurance for low-income individuals. There were health insurance marketplaces to allow individuals to buy insurance. And then there were also provisions to the Affordable Care Act, such as essential health benefits and removal of pre-existing condition exclusions that improved access to care for people who already had insurance, in addition to millions of Americans gaining insurance under the Affordable Care Act. The question is what impact could these have on health in ovarian cancer? Advance. So our study was a differences in differences analysis using the National Cancer Database, looking at trends prior to the Affordable Care Act and after the Affordable Care Act in 2 groups of women. A treatment group, so those women likely to be impacted by the Affordable Care Act, were women ages 21 to 64 with stage 1 to stage 4 of ovarian cancer. So these were women who could have been impacted by the multiple provisions of the Affordable Care Act. And then our control group was women with ovarian cancer over the age of 65, who are most likely to be enrolled in Medicare, and there were not substantial changes in Medicare during the study period. And so then the analysis is comparing the trends in the treatment group to the trends in the control group. And then this analysis is controlled for multiple variables through a regression model known to impact access to care and access to insurance in ovarian cancer. So the next slides will be results. On the x-axis is going to be time. So we looked at our pre-period was 2006 to 2009. Our post-ACA period was 2011 to 2014. There'll be a line marking the time of the Affordable Care Act in 2010. And then on the y-axis is going to be the percent of our outcome, starting with early stage diagnosis, that is women diagnosed at stage 1 or 2 of ovarian cancer, and then proceeding to percent receiving treatment within 30 days of diagnosis, so delays in treatment. The green line is going to represent our treatment group, those women ages 21 to 64 with ovarian cancer. The blue line is going to represent our control group, women age over 65, Medicare eligible with ovarian cancer. Advance. So the first result slides, we're looking at trends in early stage diagnosis under the Affordable Care Act. And what we see is over time, in our green line, our treatment group, you see an improvement from around 34% being diagnosed in early stage in 2006 to around 40% being diagnosed in early stage in 2014. And then when you compare this to our trends in the older women, first of all, older women are less likely to be diagnosed in early stage. And while we do see an improvement when we do our differences in differences analysis, the improvement in our treatment group, our younger women with ovarian cancer, is substantially larger than the improvement in our older group of women, meaning we see a positive differences in difference or a positive change in early stage diagnosis attributable to the Affordable Care Act when we compare our two groups. Advance. Next, we're looking at delays in treatment, 30 days or more. Again, our green line is our treatment group. Younger women were more likely to receive timely treatment throughout the study period. Older women were less likely, our blue line, less likely to receive timely treatment throughout the study period. And what you actually see looking at our Medicare eligible or our control group is that actually they had more delays in care during the study period than at the start of the study period. Whereas our treatment group or women impacted by the Affordable Care Act had a slight improvement in timely receipt of care in ovarian cancer. So in our differences in differences model, when you compare the two groups, the ages 21 to 64 and ages 65 plus with ovarian cancer, we see a trend of about 2% more women receiving timely care in our younger group of women impacted by the Affordable Care Act. Advance. So the final two slides are looking at publicly insured women under the Affordable Care Act. First, looking at early stage diagnosis. So again, our younger women, our treatment group, were more likely to be diagnosed at early stage throughout the study period. And you do see a substantial improvement from around 25% being diagnosed at early stage at the start of our study period to around 35% being diagnosed at early stage at the end. You see a small improvement in our control group, but in a differences in differences model, we see a significant improvement in early stage diagnosis for publicly insured women under the 2010 Affordable Care Act. Advance. Our final slide is looking at delays in treatment of 30 or more days for publicly insured women. Again, our younger women were more likely to receive timely care throughout the study period compared to our older women. And again, we see here that for our older women, there's actually an increase in delays of care more than 30 days throughout the study period, whereas for our younger women, it's holding steady to slightly improving. So when we look at our differences in differences model, we see an improvement in receipt of timely care for our younger women with ovarian cancer attributable to the Affordable Care Act. And finally, implications of our study. So under the 2010 Affordable Care Act, women with ovarian cancer were more likely to be diagnosed in early stage and to receive treatment within 30 days of diagnosis. As stage and treatment are the major determinants of survival in ovarian cancer, these gains under the Affordable Care Act may have long-term impacts on the survival, health, and well-being of women with ovarian cancer. Thank you so much for your attention. Happy to take any questions at the end of the panel.
Okay. Thank you so much, Dr. Smith. So she's going to stay on the line, and she'll be available for questions later in the question session. But for right now, I'm going to ask Dr. Markham to make some additional remarks about this study.
Ovarian cancer is a deadly disease, and we know that women who are diagnosed at later stages have much worse survival than women who are diagnosed at early stage 1 or 2. What's interesting about this study is that it shows that access to health care can help eliminate disparities in ovarian cancer. And access to healthcare ultimately may actually improve long-term outcomes by increasing access to earlier diagnosis and access to earlier treatment. It's crucial for these women with ovarian cancer.
All right, great. So you're going to see a theme in these first three presentations, and we'll go on to, so please join me in welcoming Dr. Kamal Shamoun, who's a fellow with the Hematologic Malignancies and Stem Cell Transplant Program at the University Hospital Seidman Cancer Center in Cleveland, Ohio. Dr. Shamoun.
Good morning. First, I would like to thank ASCO for selecting our study to be presented in this press briefing. No? Okay. So, first, I would like to thank ASCO for selecting this study to be presented in this briefing. Really? Okay. The outcome of patients with multiple myeloma has dramatically improved over the past 30 years. This was mainly due to the increased use of novel agents and to the increased use of autologous stem cell transplantation. However, this gain came at the cost of increased financial toxicity for these patients. Multiple myeloma is now the #1 cancer treated with oral anti-cancer medications. And these medications are often very expensive, and the patient's share of the cost differ widely among patients according to their prescription plan. A study showed that the proportion of treatment costs attributed to medications nearly tripled from 2000 to 2014. Most importantly, another study showed that the out-of-pocket cost for patients with Medicare is significantly higher than patients with other types of insurance. This does not only affect the quality of life for patients, but also affect the adherence to medications. Another study showed that 17% of patients reported delays in their treatment because of cost. 12% reported filling only a part of their prescription because of cost, and 10% reported discontinuation of their treatment because of cost. Based on this, we use the National Cancer Database, which is a hospital-based database that houses data on 70% of cancer patients in the US, to test the hypothesis of whether insurance affects the survival of patients with multiple myeloma. We selected patients diagnosed between the year 2005 and 2014. We looked at the insurance status at diagnosis. We did not have changes in insurance. We looked at the median household income in the patient's zip code area based on the year 2000 US Census. Among other variables like age, gender, race, Charlson-Deyo comorbidity score, transplant status, and treatment facility type. Major limitations of this study are its retrospective nature. There was no disease-specific characteristics, no specific information on the treatment received and the duration of treatment, no information on the subtypes of insurance. We had a total of 117,926 patients. Median age was 67 years. 55% were males, 76% were white, 20% black, 3 of other races. The median follow-up was 30.2 months. There was 54% with Medicare, 36 with a median age of 74 years, 36% with private insurance with a median age of 57, 6% had Medicaid with a median age of 58, 3% were not insured with a median age of 57, and 1% has other government insurance with a median age of 61. When we adjust for patients 65 years and older, and we look at the survival between patients with Medicare and private insurance, we see that there is a survival advantage for patients with private insurance, with a median survival for private insurance patients of 41.9 months compared to 30.8 months for patients with Medicare. The graph on the top left showed the distribution of patients according to their insurance and their median zip code-based household income. Green represents more than 46,000 median household income, pink between 35 and 45.9, blue between 30 and 34.9, and purple less than 30,000. We can see that the proportion of patients with higher proportion of patients with higher income had private insurance. When we plot this on survival, we can clearly see that patients living in higher income areas had survival advantage. The graph on the bottom left showed distribution according to their treatment facility type. Green, patient treated in a network cancer program, in a facility that is part of a network program. Pink, patients in academic institutions. Blue, patient treated in a comprehensive community centers, and purple, patient treated in smaller community hospitals. Looking at the survival according to their treatment facility type, we can clearly see that patients treated in academic institutions had better survival, followed by patients treated in a hospital part of a network, followed by patients treated in a comprehensive community center, and lastly, patients treated in smaller community hospitals. When putting all these variables in a multivariable analysis that account for age, gender, race, primary versus secondary disease, comorbidities, hospital type, zip code-based median income, and the insurance type, we see that patients from areas with higher median zip code-based income had improved survival. Treatment in an academic setting was associated with survival advantage. Older age and comorbidities, as expected, adversely affected survival. When looking at Medicaid and those without insurance, we saw that privately insured patients had better survival than patients with Medicaid and without insurance on the multivariable analysis. On this adjusted analysis, the difference in survival between Medicare and private insurance was not statistically significant. Thank you.
Okay, thank you so much. As you can see, these are complicated analyses. So I'm going to ask Dr. Catherine Diefenbach to make some additional comments about the significance of the research and interpretation of the findings.
Thank you, Dr. Shamoun, for that really important abstract. So where you live and what insurance you have should not affect the length of time that you survive multiple myeloma, though unfortunately it seems from Dr. Shamoun's study that it does. And Dr. Shamoun analyzed demographic statistics from the National Cancer Database and identified multiple socioeconomic factors, including having private insurance, living in a regionally high-income area, or receiving treatment at certain specific settings, particularly academic practices, as being associated with not only better survival, but longer survival for patients with multiple myeloma. Multiple myeloma affects more than 32,000 people every year, and it is an incurable disease. That means every year 32,000 people are diagnosed with multiple myeloma and generally live with it for either a long or short time, but to the end of their days. And during this time, they're dependent not on infusions that they receive in the doctor's office, but on oral medication, which over the last 5 years has had an increasingly higher cost and require higher out-of-pocket costs than copays. This creates major challenges with respect to access to medication. In my practice, I primarily see lymphoma patients, but I have some myeloma patients. I had a patient whose out-of-pocket cost for his medication was $20,000 a month. He was not able to afford that, and my staff and our billing coordinators were able to work to get his copay assistance and get his costs down to something like $40 a month. But not all patients have access to that kind of infrastructure, and they're forced to make very challenging decisions about whether they take this medication, whether they're compliant with taking it every day, or whether they hoard their pills and take it on a less frequent basis. And we're seeing from Dr. Shamoun's study that these challenges are creating real differences in survival. As a society, we should strive to ensure that every patient, no matter what their socioeconomic status or their location, receives equal access to high-quality cancer care.
Thank you so much. And, you know, I think the take-home message from all these abstracts really is about access to care. You can't get care, you can't benefit from all the advances in cancer treatment that are being reported every year at the ASCO annual meeting. So the next missing a page in my script. Well, this is looking at the relationship between expansion of Medicaid under the Affordable Care Act and timeliness of treatment initiation. So we're going to invite Dr. Amy Davidoff to the podium to give the presentation.
Thank you, and I am pleased to be here today presenting the results of our study on behalf of Dr. Adamson and our co-authors, and thank you to the ASCO Plenary Session Committee for selecting our research for presentation. Racial disparities, next slide. Racial disparities, oh, I can do it, sorry. Racial disparities in cancer-related care access and outcomes exist across the trajectory of cancer care, from prevention to survival and other health outcomes. They remain a societal challenge. And while these disparities have been well documented, finding mechanisms to reduce disparities is more challenging. An important aspect of care is timely initiation of treatment after diagnosis, which is patient-centered and may improve clinical outcomes in some scenarios. In this study, we focus on timely initiation of systemic therapy after diagnosis with an advanced or metastatic cancer. One potential mechanism to reduce treatment disparities is to improve access to insurance coverage. As my previous colleagues have noted, the Affordable Care Act, passed in 2010, allowed states to expand Medicaid coverage to poor and near poor adults up to age 64, as well as establishing private insurance marketplaces with subsidized premiums and cost-sharing reductions for qualifying enrollees. By January 2019, 33 states and Washington, D.C. had implemented full expansions. Our study hypothesis is that Medicaid expansion reduced disparity in timely treatment for Black patients compared to white patients with advanced cancer. Our data source is relatively unique. We use data from the Electronic Health Records database from the Flatiron Company, and data from the Kaiser Family Foundation on Medicaid expansion by state and time. Our study sample included adults aged 18 to 64 years diagnosed with advanced or metastatic cancer. Our outcome is receipt of systemic therapy within 30 days after diagnosis with an advanced or metastatic cancer, which we refer to as timely treatment. Systemic therapy includes chemotherapy, hormone, targeted, and immunotherapies. Diagnosis date with advanced or metastatic cancer is based on the first date mentioned in either a clinician text entry or pathology reports from the electronic medical records. This is a retrospective observational study. We selected a cohort of patients and observed whether they received timely systemic treatment. In our analysis, we compared patients diagnosed under Medicaid expansion versus not, and we assessed whether the expansion status affected treatment timeliness for Black patients differently than white patients. We used regression analysis, and we adjusted our analysis for patient characteristics, cancer stage and initial diagnosis, practice characteristics, and unchanging state and time trends. You can see in our figure here what we're measuring is the difference in timely treatment for Black patients compared to white patients, which we call our racial disparity in the non-expanded, compared to that same difference in the expanded. And as I mentioned, for our hypothesis, we expect that the difference between them will be smaller under Medicaid expansion. Our results. We had over 30,000 patients in our sample. The distribution by diagnosis is reflected in the figure on the left, and you can see that non-small cell lung, colorectal, and breast cancers were the most prevalent. We present some demographic characteristics on the right-hand side, and you can see that there are differences by sex and race between the expanded and non-expanded scenarios. The differences by race are consistent with the demographics in the states that eventually expanded Medicaid compared to those that have not, which are primarily in the southern U.S. The key results. And they are all adjusted for there were adjusted levels for all covariates in our regression model. So we're adjusting for differences in age and sex, et cetera. We see that overall, for patients diagnosed under a non-expanded scenario, that 47.7% received timely treatment. The difference, though, between Black patients and white patients was substantial and significant. 48.3% of white patients received timely treatment compared to 43.5%, a difference of 4.8 percentage points. But under Medicaid expansion, that difference was diminished dramatically, almost disappearing. After expansion, 50.3% of white patients received timely treatment, 49.6% of Black patients, a difference now of 0.8 percentage points, and as I said, is not significant. Basically, the expansions totally disappeared. The disparities disappeared under the expansions. So in conclusion, Medicaid expansion was associated with reduced racial disparities in timely cancer treatment. As I noted, a 4.8 percentage point disparity was reduced to a 0.8 percentage point non-significant difference, and which meant that Black patients benefited much more than white patients by the expansion to the tune of a 4.0% reduction in disparity. This extends prior evidence regarding the effects of the Affordable Care expansions on insurance coverage and general access for cancer patients. It also tells us that national healthcare coverage policy may reduce disparities in cancer care. And finally, that electronic health record data with large sample size and diverse coverage can be a very valuable resource for research on treatment patterns, disparities, and interventions. Thank you.
Okay, thanks for that lovely presentation. So now I'm going to turn to Dr. William Dale to provide some additional context for this report.
Great. Thanks so much, Rich. This was really delightful for me. ASCO's made a commitment to studying these issues of disparities and equity, and I think having something on the plenary session is wonderful, and this work is to be commended. I think it's some of our best evidence we've had to date that a specific policy change can have an impact on disparities in health equity, particularly with regard to the timing of treatment. So it's very specific, but very strong evidence, and it's nice to see that. You know, as was pointed out, the issue is that everyone benefited. Not statistically so for the white patients, but that everybody had some level of improvement. It was just those that were falling behind before were more likely to benefit. So the disparity went away. And it is hard to make disparities disappear. We often can see some reductions, but to actually have it go away is impressive. One other thing that stood out to me in this study was it's very hard in social science to get that wonderful randomized study that we get in so many other ways. So to have a good group to compare it with is unusual. Here, because of the design of the policy, which was states that did accept versus states that did not, we were allowed to have a good comparison group to say what would have happened. It's not randomized, so there are some caveats to that, but with the statistical controls and the size of the sample, it was very impressive to see that there was a noticeable change that was statistically identifiable. I love when these natural experiments can be used to inform policy. So thank you to Dr. Davidoff and her colleagues.
Great. Thank you, William. So the first of which will be presented by Dr. Christopher Sweeney, the medical oncologist at the Lank Center for Genitourinary Oncology at Dana-Farber Cancer Institute in Boston. He will present the findings from a randomized phase 3 trial evaluating the impact of adding enzalutamide to standard initial treatment for metastatic hormone-sensitive prostate cancer. Dr.
First of all, thank you very much to ASCO for giving us the opportunity to present these results, and also for everyone making their time this morning to come and hear the results. First of all, I'd like to just emphasize that this trial called Ends Up is an academic global collaborative trial, and there are some differences from this study that was presented on Friday with a similar drug, apalutamide. One is that this is academic, and there are some differences in the designs that come from it being an academic study where we had some more flexibility to respond to the changes in treatment that were occurring. I'd also like to say that this is a wonderful collaboration between the Clinical Trials Centre based in Australia, Cancer Trials, Canadian Cancer Trials Group, CCTG, Cancer Trials Ireland, and the Dana-Farber Cancer Institute, and it was led by a new cooperative group out of Australia called ANZUP. I'm an ANZUP member as well, but based in Boston, and I had the huge honour of presenting the results on behalf of Ian Davis, study co-chair, who's with us, and the co-authors. That went the wrong way. This goes the right way. By way of background, until 2014, testosterone suppression, plus or minus the standard anti-androgens, was the only therapy. We knew patients with a higher burden of disease had a shorter overall survival, and that was the state of affairs for about 70 years. Improvements in outcome for hormone-sensitive prostate cancer emerged with the use of agents that were active in castration-resistant disease when cancers were growing with a low testosterone. With agents like docetaxel, in 2014, we presented the results of the CHARTED study then, and in 2017, we learned about the results of a hormone, abiraterone, that also improved the survival of men when used in the hormone-sensitive setting. Enzalutamide is a potent direct androgen receptor inhibitor, so another type of hormonal therapy. Again, it's been shown to work in men with castration-resistant disease, namely disease growing despite a low testosterone. At GUASCO, we learned that enzalutamide delayed the time to progression as measured by changes on scans, and this study allowed patients to have had prior docetaxel based on the CHARTED data. The study was called ARCHES. Janssen Pharmaceutical Company had the results presented at ASCO on Friday of apalutamide, showing that it prolonged progression-free survival and overall survival, and again, it allowed prior docetaxel. ENZAMET is the first trial to present the overall survival results of enzalutamide plus testosterone suppression and the outcomes if patients also received concurrent docetaxel. And there's the key difference that I want to highlight. The design was quite simple. It was testosterone suppression alone with the non-steroidal. So the other differentiating factor is that we actually put in the weaker anti-androgens, which were the standard, not a placebo, but the actual standard of care, which has some activity, with and compared that to testosterone suppression plus full dose, more potent androgen receptor inhibition. We stratified patients by their volume of disease, good prognosis versus poorer prognosis, planned use of the early docetaxel concurrent with the enzalutamide, performance status, and use of agents like denosumab and zoledronic acid, and how fit a patient was, their comorbidity scores. Notably, the patient population was representative of prostate cancer in terms of age, 69 years. Notably, this was a global study with most of the accrual coming out of Australia and New Zealand with 60% of patients, Canada with about 20%, the UK and Ireland of about 17%, and the United States is represented by just one institution, Dana-Farber, at about 4%. Notably, we had about 45% of patients receive concurrent docetaxel, which differentiates itself greatly in terms of not only being concurrent, but the frequency of use of docetaxel, recognizing that some patients' standard of care is testosterone suppression alone, and about half the patients, testosterone suppression with the docetaxel is the standard of care, depending on a patient's chemofitness and how much cancer they have in their prognosis. We also note that half the patients had a poor prognosis with a greater burden of metastases, namely 4 or more bony metastases. Visceral metastases is what high volume is defined as. The highlight is that we actually saw at the first interim analysis, so this is the first look, and we were told to report the results early because there was a survival benefit already seen after half the information was received. The first thing to note is that there was a 33% decrease in the rate of death, the hazard ratio of 0.67. It was statistically significant at the level to say that we should report the results at the interim analysis, so it was a very stable result. But in absolute terms, for the overall group, it meant that there was an increase of percentage of patients alive at 3 years, as an easier way to reference this, going from 72% to 80%. What we did note also is that the therapy significantly delayed the time to PSA rise on therapy or clinical progression or death. And then when we took out the variable of PSA rise, we noted that there was also a longer time to clinical progression independent of the blood test, namely worsening changes on images, symptoms, or signs that the patients experience from their progressive cancer. Both of them had a hazard ratio of about 0.39.4, meaning there was a 60% decreased rate of progression at any one time. When we broke this study out, and this is where the long conversation is going to be, we saw that when docetaxel was added to the testosterone suppression, there was again a significant improvement in the, or delay in the time to progression, as seen in the top left curve, but the top right curve, we actually do not see a significant treatment effect on overall survival at this early analysis, with a hazard ratio of 0.9, and so that's the first information that we as the investigators will have to think through of what treatment to give our patients if they've had docetaxel. However, two things. Most of those patients who got docetaxel had the high volume, were the poor prognosis patients who do benefit from the early docetaxel. On the other hand, men who did not have the docetaxel, there was a significant delay in the time to progression again, with a hazard ratio of about 0.66, 66% decreased rate of progression, but the overall survival benefit was quite marked, with a 47% decreased rate of death in those patients. Mostly, these patients were the low volume, good prognosis patients who we have not seen benefit from the early docetaxel. Side effects is a very real factor when we compare not only the treatment benefit, but what is the cost in terms of adverse events. Enzalutamide has got some associated fatigue, hypertension, and some men have some frailty in the 5% range, which may have them have some falls and be a little bit frail. And we as physicians have to say, are the patients fit enough, even for the hormone enzalutamide? And there are some side effects and concentration impairment that we need to be counseling our patients about the risks. So the overall conclusion is early enzalutamide substantially improved the time to progression and overall survival when added to testosterone hormone, standard metastatic hormone-sensitive therapy, be it testosterone suppression alone or with docetaxel. The clinical interpretation is enzalutamide added to testosterone suppression represents an appropriate option for men with metastatic prostate cancer, commencing testosterone suppression. The benefit is clear in both low and high volume patients, which distinguishes what we know with docetaxel. There is a delay in progression with an improvement in overall survival, but there is toxicity. And what I didn't show here, but will show in the presentation, is that the enzalutamide actually increased the docetaxel-related toxicity that needs to be reconciled. We do plan to do quality of life analyses, and we may actually see that there's a benefit from adding the enzalutamide to the docetaxel if there's a meaningful quality of life improvement, or longer follow-up actually shows that there's improved survival over 3 years. And I thank everyone for their attention and highlight again this wonderful academic global collaboration that I had the honor to be a part of. Thank you for your attention.
Okay, thanks, Chris. So I'm going to ask ASCO expert Dr. Neeraj Agarwal to provide some additional context. There's been a lot of advances in the treatment of prostate cancer in recent years. It's always complicated to figure out where to place some new data. So Dr. Agarwal, can you clear it all up for us?
Yes. So advanced prostate cancer is the second most common cause of cancer-related deaths in American men. The current treatment options for men with newly diagnosed advanced prostate cancer include chemotherapy, as Dr. Sweeney mentioned, or an oral pill, abiraterone, which require concomitant use of steroids for many years. What we saw in this study is that enzalutamide, or Enza, to make it simple, an oral pill, which is a novel class of drugs for these men, and targets AR, androgen receptor, a protein which is critical for disease progression in these patients. So targeting AR with enzalutamide improved the overall survival in a very remarkable fashion. Remarkably, the disease-free survival was also delayed. So what are the implications of this study? Or how do we analyze the findings in a simple perspective. In my view, using enzalutamide early on will allow our patients to avoid chemotherapy and steroids for many years, thus hopefully improve their quality of life. And of course, one positive study is encouraging, but two large studies, as Dr. Sweeney mentioned again, demonstrating similar findings is even better. In this meeting, we saw the data for apalutamide, a similar drug with an equally impressive margin of benefit. This increases my confidence that targeting AR, this protein, is the optimal approach for newly diagnosed patients with advanced prostate cancer.
Exploring maintenance therapy with the PARP inhibitor drug called olaparib among people with pancreatic cancer who had an inherited BRCA gene mutation. You may not realize that a small percentage of patients with pancreatic cancer do carry the BRCA gene, and that turns out to be an important feature of this study. So please welcome Dr. Hetty Kindler, who's professor of medicine at the University of Chicago, to present the study.
It's my pleasure to present the results of the POLO trial to you today. Metastatic pancreatic cancer is a dismal disease. Even with modern chemotherapy regimens, patients generally live less than a year. Historically, most do not receive second-line treatment. There are no targeted therapies for this disease in a biomarker-selected population validated by a phase 3 trial. 4 to 7% of pancreatic cancer patients harbor a germline BRCA1 or BRCA2 mutation. They obtain an increased benefit from platinum-based chemotherapy. Maintenance treatments aim to delay disease progression following chemotherapy without compromising quality of life. Olaparib is a PARP inhibitor that targets cancer cells that have a defect in DNA damage repair. The study design for POLO is shown here. Eligible patients had metastatic pancreatic cancer and a germline BRCA1 or 2 mutation. Patients had received at least 16 weeks of a first-line platinum-based chemotherapy without progression. There was no maximum limit to the duration of chemotherapy. 38% of the identified germline BRCA mutated patients had disease progression, were ineligible, or declined randomization. The remaining patients were randomized 3-2 to olaparib tablets, 300 mg orally twice daily, or placebo, and continued until investigator-assessed disease progression or unacceptable toxicity. The primary endpoint was progression-free survival by blinded, independent central review. Progression-free survival was measured from time of randomization, which was after the completion of first-line chemotherapy. Progression-free survival was 7.4 months on the olaparib arm and 3.8 months on placebo, with a hazard ratio of 0.53 and a p-value of 0.0038. This represents a 47% decrease in the risk of progression or death. The objective response rate by blinded independent central review in patients with measurable disease was 11.5% for placebo and 23.1% for olaparib, which included 2 complete responses. Time to onset of response was earlier in the placebo arm, suggesting that these responses were a carryover from first-line platinum-based chemotherapy. What is truly remarkable is that the median duration of response to olaparib in these patients who had metastatic pancreatic cancer was more than 2 years. In conclusion, maintenance olaparib provided a statistically significant and clinically meaningful improvement in progression-free survival to patients with a germline BRCA mutation and metastatic pancreatic cancer whose disease had not progressed during platinum-based chemotherapy. Interim survival data showed no difference between arms. We are still awaiting final survival results, which will be evaluated at 69% data maturity. Maintenance olaparib was well tolerated with an AE profile similar to that seen in other tumors. Health-related quality of life was preserved with olaparib treatment and showed no difference between arms. Our results are the first from a phase 3 trial to validate a targeted treatment in a biomarker-selected population of pancreatic cancer patients, highlighting the importance of germline BRCA mutation testing in this setting. We conclude that a strategic approach of first-line platinum-based chemotherapy followed by maintenance olaparib treatment should become a new standard of care for patients with metastatic pancreatic cancer who have a germline BRCA mutation. Thank you for your attention.
Okay, well, that was some really exciting data that I'm quite sure will change the face of treatment for at least this population of patients with pancreatic cancer. So for some additional comments, I'd love to hear from Dr. Suzanne Cole, one of ASCO's experts.
I completely agree with you that this is a really huge step forward for patients with metastatic pancreatic cancer. This is the first time that a targeted medication has been successful in stopping the growth of metastatic pancreatic cancer in people who carry the BRCA mutation. More patients with metastatic pancreatic cancer who also had a BRCA mutation saw their disease go dormant and when they received the olaparib. And at 2 years, 20% of patients were still alive with excellent disease control because they were taking the olaparib. And now that we have a targeted medication that can benefit patients who have the BRCA mutation when they present with metastatic pancreatic cancer, it is our duty to search for this genetic mutation in all patients with metastatic pancreatic cancer so that we can identify those people who have the BRCA mutation and can benefit from being treated with an oral agent that can extend their life. And just to put this into context for you, I'd like to tell you about a patient of Dr. Kindler's who enrolled on the POLO study. He was diagnosed with pancreatic cancer, and at the time of diagnosis, it had already spread into his liver. He had inherited the BRCA mutation, as had his brother, and he had recently seen his brother die of metastatic pancreatic cancer within a few months of his diagnosis. And because this patient wanted to have a different outcome than what had happened to his brother, he decided to enroll on a clinical trial to see if he could get a better outcome. So he got onto the POLO study, he received chemotherapy for about 4 months, and then he was able to move over to the olaparib, which is a pill, and he has now been alive for 2.5 years, and not only have the tumors in his liver stabilized, they've actually decreased in size. And he has had really excellent quality of life because he's been free of taking IV chemotherapy over this time. So I think this is practice changing for people who have the BRCA mutation. I can't wait to go back to clinic on Tuesday and look for it in my own patients. And congratulations, I think this is a fantastic.
About the POLO trial first, because Dr. Cole has to leave for another engagement. So I'm going to ask those of you who want to ask a question about the POLO trial to come to a microphone now while I'm asking you one other question about what is the role of ascertaining the family history in determining whether or not to do germline BRCA testing in these patients?
So I think that it's good medical practice to pay attention to what's going on in the family and whether there are cancers that we know are related to BRCA mutations, such as breast cancer, ovarian cancer, prostate cancer, and now pancreatic cancer, to tip you off that you may need to be searching for the BRCA mutation in your own patient, especially in light of this new data that may really extend their time alive.
Okay, so we're going to take questions about the POLO trial, and then we're going to sort of open it up to all the other studies. So please identify yourself and ask your question.
Hi, Richard from Pharma Forum. So this thing about BRCA sequencing came up yesterday with the prostate cancer, and the comment from one of the expert in the sort of plenary session was that there was an issue with whether or not the technology is there to actually find these mutations. I mean, I know you've just alluded to the fact you can look for family tip-offs, but not necessarily always going to be the case. So how are we with that situation, and when do you see this kind of becoming maybe a more standard practice to like have the sequencing there ready to look for this thing?
In this particular study, we are looking at germline mutations that are found in the blood and not somatic mutations in the tumor. So the technology is completely there. It is standardized. It has been used for years in breast cancer and ovarian cancer, so there is no issue with that.
Hello, Annette Brindle from BioWorld. I have two questions actually, and one is also about the mutations. Could you look for them could you look for somatic mutations as well, and would you expect that that would confer a benefit?
One certainly can look for somatic mutations or the concept of BRCA-ness within the tumor. This study did not address that. That's something for a future study. So this study simply looked for the inherited mutations in the blood.
Okay. And second question, I find it remarkable that your overall survival data aren't mature yet. So what are the survival rates at this point, and when will they be mature? I mean, I know it says it's 69%. I just don't know what that means in practice.
Sure. So I'll be presenting the data, of course, later today, and we are currently at the data cutoff in January. We are at 46% maturity. It is indeed remarkable that we haven't reached a survival endpoint in a disease where patients usually live around a year, so it's great. It will occur at some point later this year. I would expect we would have that.
You're not about POLO. Anyone else have a question about the POLO trial? Okay, if not, we're going to excuse Dr. Cole for her next commitment. And please, questions now open for any of the studies presented today.
Hi, Neil Osterweil with Oncology Practice. A question for Dr. Shamoon and one for Dr. Davidoff as well. Dr. Shamoon, do you think that you could have come at this issue by maybe looking at pharma databases, looking at prescriptions for let's say lenalidomide and bortezomib, that kind of thing?
So, of course, we did not address this in this study because the database did not have information about specific treatment. We definitely love to have other data sets that can have information about specific treatment that patient received or discontinued, and we'd love to look at how many patients with private or Medicare discontinued or a specific treatment, but we don't have this data.
Okay, thank you. And Dr. Davidoff, could you please put in context what that 4% difference might mean in terms of numbers of people, or are you able to quantify that?
Fortunately, if you think about sort of, this is looking at patients with metastatic or advanced disease, and so most patients who die of cancer in the U.S. will have gone through some period of advanced and then to metastatic disease. So it's a very large number. Unfortunately, I don't have that, but I'm happy to get back to you. But the 4.8%, that's about a 10% difference in that timely treatment difference. And that was a significant difference for Black patients, white patients.
Thank you.
This might not hear me. Shri Ananda from MedWire News. Thank you.
Maybe you can just tip the microphone down there. Okay.
That'll do. Thank you. A quick question for Dr. Sweeney, and then one for Dr. Sweeney and Dr. Agarwal. The quick one is, what was the rate of discontinuation due to adverse events?
So 60% of patients were still on enzalutamide at the 3-year mark. 33% were still on therapy on the non-steroidal arm. There was a slight increase in the number of patients who stopped because of adverse events on the enzalutamide, 33 patients versus 14% on the non-steroidal. So it was overall well tolerated. and the story is yet to be told in full because we've got still 66% of patients on therapy, which is at 3 years.
And then the question for both of you, with the Enzamet results and the Titan results and the others, abiraterone and everything, how do physicians choose?
I also think chemotherapy is in the mix as well,
Yes.
in as much as you could possibly do for patients who are fit for chemotherapy and have a high burden of disease. There's a benefit for chemotherapy, and you could possibly get the chemotherapy, be on a treatment break, and then come back to these hormones. To be honest, there'll be a Pepsi-Cola, Coca-Cola war like we had with paclitaxel and docetaxel and many of our other diseases, to be honest. Abiraterone has the benefit of being able to be given to patients who don't have who have a seizure risk. Enzalutamide is probably a better drug, or apalutamide in patients who have risk of diabetes and you want to avoid the prednisone. So physicians and patients have to sit down and make choices based on their financial concerns, their comorbidities, and what their patient and physician preferences are when they discuss. All options have to be on the table.
Dr. Agarwal, anything to add?
I agree with Dr. Sweeney. Just like to add, I have had very few patients, and sorry about my hoarse voice. I've seen very few patients who are really enthusiastic about receiving chemotherapy. So clearly, when we have oral pills which allow our patients to not receive chemotherapy and long-term steroids, is an enormous advance in my view. And we have 2 of them being reported in the same meeting, which is very exciting in my view. So both enzalutamide and apalutamide will allow my patients in the clinic to avoid chemotherapy. And that's a message I'm going to get from these 2 presentations.
So my question is just more about apalutamide, if I may, because Enza is obviously the older drug. So do you think there's going to be a cost factor where people are going to be choosing between apalutamide and enzalutamide, or is it going to be more of a clinical thing? How do you think it's going to pan out?
The side effect profile are slightly different, rash being with one, fatigue a little bit more pronounced with enzalutamide maybe. But the big issue is the cost will be the same. Both of them are still on patent, and we still are in the $10,000 a month list price of sorts. And as described earlier, it's anywhere between $5 and $10,000. A lot of patients have copays, which end up being $2,500. Going through the donut hole in the United States is one question. And then on the other side of that is, are they means tested to get patient assistance? This question is very different, and what's great about this study is that there's a global perspective that we're not talking about, where government payer systems will make it a lot easier, but we have to show the data that there's a quality of life benefit, the financial healthcare utilization is beneficial, and we will get that data out of the Enzamet study. Actually, to go to the thing, I think there is a notion, I'll be a little bit contentious, if that's what you like of this type of thing. There's a bit of chemophobia. Patients and physicians may have a fear, but you've got to be careful as to who's fit for it. But you could actually save a lot of money by giving the chemotherapy and then adding the hormones on, which have a longer-term toxicity profile, because you're on it for much longer, 3 years of these drugs with a side effect profile. And I think we have to present both options, and you're fit for chemotherapy most likely when you're starting the hormones, and if you're fit, get it out of the way and then come back to the hormones. So I do still think if you want to have a lower treatment burden possibly in the long term and a lower cost, it is something that should still be considered.
Hi, Caroline Helwig, ASCO Post. Back to the mutation information from Dr. Kindler. So if you did test for somatic mutations, in the future, what additional percentage of patients might be eligible for this drug? Because I assume maybe they wouldn't have a germline, but they could have a somatic.
So that data really is not available in pancreatic cancer. Again, we studied this in patients with germline mutations. There are ongoing studies looking at this in somatic mutations, but I really can't tell you how active this would be.
Okay, but they could identify an additional group of patients for whom this would...
The goal would be to try in the future to identify additional patients who this might apply to.
Okay, thanks.
Hi, I'm Peggy Peck. I'm with BreakingMed.org. I have 2 questions. The first one is a little bit of confusion that I have and one of my colleagues have, Dr. Schumann, on your slides, because as the survival data, where it showed on the one slide that it appears to be a statistically significant difference in survival for the Medicare versus these private insurance. And then in your conclusion, you said it was not. So could you please explain that?
Yes. So when we only look at the insurance type, Medicare versus private insurance, we do see this difference. But then when we adjust for confounding factors, these factors were the age, comorbidities, the zip code-based income, and the hospital or the treatment facility type. These confounding factor abolished this difference. So this is when we see that the difference disappears when adjusting for these factors.
And now the other question I have is sort of a more global question that involves this access issue. Because we've presented here, I've sat and I listened to 3 presentations that dealt with how important access is for improving care. We are at a point now where it is very possible that at least part of this access that you're talking about, the ACA, may go away by a legal challenge. So I need to ask, what is your sense? I mean, it's taken this long to come out and say, oh, look at this, where there's a benefit. If it does go away, what in fact would happen then? What, use your crystal ball and tell me. And I'd like, I'd like any of you to jump in and say, how important is it to have some, plan B?
Give us what plan B could be.
Okay.
Living in the United States, this is really
I
good.
think you're kind of safe there,
Yeah, no,
and stuff.
We've all been sort of trying to think this through. In some sense, I'm going to throw it back to ASCO leadership standing at the front to comment on ASCO's policies. But from the policy perspective, my degree's in policy. It's exciting that we at least have some data so that if we're going to make future policy decisions, I can't control the political process, but to say, here's some evidence, here's the kind of evidence it is, just like we would in any other arena, then we can start to hypothesize what the consequences would be of changing policy with some evidence that we can trust. And I think that's the most important thing that we push for, evidence-based policy. Politics is outside of my realm, and ASCO has its own policies. I will say this, it's hard to imagine people being against equitable care. Of all the great things that we have, we're all for it. And if we have evidence of things that improve equity, I think we can get behind that being a good thing.
So let me just say, on behalf of ASCO, ASCO has a clearly stated set of principles that we believe should apply in the development of any healthcare reform in this country. We've published those. We've advocated for those. They include, core principles. Every patient with cancer should have access to high-quality cancer care delivered by a specialist. Every patient should have the opportunity to be screened for early detection of cancer. Every cancer patient should have the opportunity to participate in cancer clinical trials. We have not taken a stance, including regarding the ACA, on any particular healthcare plan advanced in the Congress. However, we have been critical of those that have not been adherent to ASCO's core principles, including those that I just stated. So we're happy to provide anyone who's interested a copy of our full set of principles regarding access to healthcare and equity in healthcare. And it's clear that there will be an ongoing debate. There has been since the passage of the ACA. I think the data presented here demonstrates the importance of good health insurance as a key driver of access to care, timely diagnosis, timely treatment, and presumably better outcomes. And ASCO will continue to advocate for those core principles to be retained in any modification of the ACA that might be put forward.
Alice Goodman with the ASCO Post. Dr. Sweeney, I think I need more clarification around this docetaxel issue, because in your data, it looks like there's no, at this interim analysis, survival benefit for people who are on docetaxel, while there is a survival benefit for people who are not on docetaxel. But you just said it would be better to give them docetaxel first, get that out of the way, and then add enzalutamide and apalutamide.
So the reason I think there's no survival benefit is because what we'll show in the afternoon, and in the paper that's actually on the New England Journal website this afternoon, is that there is a lot of salvage therapy. So most patients got 85% of patients got one or more life-prolonging therapy, of which most of it was abiraterone or enzalutamide. So it was a little bit like a concurrent versus sequential approach of ADT docetaxel, concurrent enzalutamide versus ADT docetaxel, with the effective salvage therapies we have for castration-resistant disease, with giving those therapies when the PSA rises. We actually also note one of the contentious questions that comes up from time to time: did the patients progress and get enough therapy? Only 4% of the total patients on the non-steroidal arm who progressed died without getting docetaxel in the hormone-sensitive setting or one of the life-prolonging therapies. Only 4%, and those patients have other issues of, they may have died of another, have gotten too sick that they weren't fit enough for chemotherapy or developed health issues and were not fit enough. But that's a very low number for a randomized phase 3 controlled study where patients roll over to the standard of care. And the good news is most patients got the standard of care. Of the 15% who didn't get the life-prolonging therapies, for example, I have a patient who we stopped his bicalutamide and he's 6 months into a response from just stopping the bicalutamide based on this issue of an anti-androgen withdrawal phenomenon. So I'm very confident